Support comes from St. Louis Public Library Foundation, helping the library serve children and their families with programs and services needed to become lifelong readers. More information about the foundation is at slpl.org.
This is St. Louis on the Air from St. Louis Public Radio. I'm Elaine Cha.
They've been put in a position where they're practicing defensive medicine. Overdose rates have gone through the roof. It doesn't magically become a healthcare technology.
Think about what other questions you need to ask.
You crack down on a safer drug, and a less safe drug takes its place.
When a person gets prescribed certain medications to treat pain, that script is entered into a monitoring program. And these prescription drug monitoring programs, or PDMPs, have been around since the 1940s as a technology for law enforcement to track who is using what, especially when that what is highly susceptible to abuse or trafficking. Since the early 2000s, healthcare systems have used prescription drug monitoring programs to combat misuse of opioids. These approaches, however, haven't fixed the opioid crisis. In fact, the epidemic continues to worsen. Why? St. Louis University Associate Professor Liz Chiarello examines this and other related questions in her new book, Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis. And she joins us today to talk about this. Liz, welcome back to the program and congrats on the book.
Thank you so much.
So, can you give us some basics about how these programs work in practice? Take us through that process. When a patient is prescribed an opioid medication, what is it that happens next?
So you're prescribed an opioid. You take the prescription to the pharmacy. The pharmacy dispenses your medication, but they also enter information about that prescription into the prescription drug monitoring program. They send that information to a private company. It's called Bamboo Health. And Bamboo aggregates all of the pharmacy dispensing data across the state and then feeds that information back to healthcare providers, physicians and pharmacists, who can use it to make decisions about providing care. But they also feed that information to law enforcement, who can use that to make decisions about both patients and providers. Mm-hmm. So PDMPs are two-tiered surveillance systems.
Okay. And just to put a finer point on it, it is a state system rather than one that is between states?
It's complicated.
Okay.
So they're run at the state level, but then there's also an aggregated version. It's called PMP Interconnect that allows the state PDMPs to be interoperable. And I want to say, I don't know the exact number, but I want to say maybe it's 36 states are part of PMP Interconnect. So they're all sharing data. Mm-hmm. But there is no national PDMP. It's kind of been built from the ground up.
Okay. And all 50 states has some form of PDMP.
They do. We were the lone holdout. Missouri was the lone holdout until just a couple of years ago. But even then, we had a county-based PDMP. So we've had a prescription drug monitoring program for a while.
Mm-hmm. And I wanted to make that point because we do, here in St. Louis, we are in a bi-state region. So people are moving back and forth quite often. Liz, how is it that you decided to look into how prescription drug monitoring programs work and whether they are effective?
I had been doing research with pharmacists starting in 2009 for a different project that was actually about emergency contraception and their decisions about providing that care in the pharmacy. And as I was interviewing pharmacists, they ended up telling me a lot about opioids and the struggles that they were having with opioids. And so I changed my focus a little bit to start to look at the opioids. And then maybe around 2012, 2013, I started to see that healthcare and law enforcement and public health were all trying to work together to deal with this crisis. And I thought, these are really different institutions and they have different ways of thinking about things, different resources. And so I wanted to understand how they were working together and how they were working against each other to tackle the same social problem. Mm-hmm. And it was then that I learned about the prescription drug monitoring programs. And I thought, pharmacists have so little time. They're going to hate having this new technology and this new login. But I was wrong. They actually really liked it. And so I got really curious about how pharmacists were using it, how physicians and law enforcement, how all of these different professions were using the same technology to do different kinds of work.
Mm-hmm. And in those different kinds of work, when you were on last time in March to talk about this, you had spoken about line blurring, that things between, for example, law enforcement and those who are providing patient care, that the boundaries, so to speak, were not all that clear. Why and how did that come to be the case?
So technology is complicated, and we have to be a little bit careful that we don't give too much credit to the technology. We generally don't talk about technology doing things, for example. Mm-hmm. However, the purpose that you create technology for tends to be quite powerful. So even if you take an enforcement technology and you put it in a healthcare field, it doesn't magically become a healthcare technology. It really has to do with how it's used in healthcare spaces. And so what I find is that as physicians and pharmacists use PDMPs in their work, they start to embrace these enforcement logics and these enforcement practices. So physicians use PDMPs alongside other enforcement tools, things like urine drug screens, pain contracts, random pill counts, things we usually think about parole officers doing, not really physicians. And meanwhile, pharmacists, as they use them, change their routines, their relationships with physicians and with law enforcement, and their roles, their understanding of who they are as professionals. And so that's the work that the technology is doing alongside other sorts of social and professional pressures. I want to acknowledge that again.
Right.
It's not the tech doing all of this work.
So looking at these prescription drug monitoring programs and whether they are working in terms of what is happening with patient outcomes, there have been increases, in fact, in overdoses. How is this happening? If this tool, it is used by people, why is there an increase rather than a decrease?
This all has to do with our theory of change. So when PDMPs were adopted, the theory of change among many of the healthcare leaders and law enforcement leaders was if prescribing opioids is what's leading to overdose, then if we can cut down on opioid prescribing, we can also cut down on overdose. That's not what's happened. So prescribing rates have returned to pre-crisis levels. They went up and then they went down, but overdose rates have gone through the roof. And a lot of that has to do with the shift in the drug supply. So we went from prescription opioids contributing to a lot of deaths to heroin contributing to a lot of deaths. Now it's fentanyl. It's almost exclusively illegal fentanyl. There's also a prescription fentanyl. That's not what's causing these deaths.
Right.
And so drug policy researchers talk about this as the iron law of prohibition. You crack down on a safer drug and a less safe drug takes its place. And so that's why we're in a moment now where we're seeing a lot of fentanyl and a lot of xylazine, which is an even more problematic drug.
Mm-hmm. One of the things that stood out about your book, Liz, is that there are stories there about people who are living with terrible pain that at one point they were able to get medication for in amounts that would be deemed way too high. But what ends up happening is they live day to day with excruciating pain. And Maria Higginbotham in Seattle, Washington, is one of those people. Tell us about her story, Liz.
Maria was, I believe, in her 40s when she walked out to her mailbox one day and was suddenly struck by this excruciating pain. She went through a number of different surgeries. She had medication that was working for her. And then since then, she's been cut off of her medication, or I'm sorry, not entirely cut off, but her medication has been drastically reduced. Mm-hmm. And so it's the kind of thing that could happen to any one of us. You know, we cross one of these St. Louis city streets and somebody hits us and we're catapulted into pain. And increasingly in the healthcare system, there's a real pressure to taper patients down. Even people who've been on high doses for a really long period of time are increasingly getting tapered. And so stories like Maria's are actually really common. And I've started interviewing pain patients for my next research project, and their stories are really eye-opening.
What are the pressures, Liz, on physicians?
They come from a number of different places. So they come from law enforcement on the one hand. They also come from insurance companies. One of the biggest changes is that in 2016, the Centers for Disease Control and Prevention adopted a set of guidelines that talked about what kinds of doses physicians should be prescribing. And so one of the things they recommended was that patients shouldn't be above 90 morphine milligram equivalents. And so a lot of places, including hospitals and clinics and insurance companies, have really taken those guidelines as if they were law and started to reduce prescribing rates or encourage physicians to reduce prescribing rates. And physicians are inherently conservative. I don't mean politically. I just mean they want to be practicing well within the scope of practice.
Right.
And so they have also kind of readily reduced those prescribing rates, but that's left a lot of pain patients out in the cold.
And we're going to come back to guidelines. I'd like to talk about that a little more later. But there has also been another increase that is associated with prescription drug monitoring programs, and that's higher rates of arrest. Talk with us about that.
Higher rates of arrest.
Yeah, for insofar as people who are reporting patients for trying to get more of a controlled substance, whether they need it for a quote-unquote legitimate purpose or not.
So in the book, I talk about this as routing. I talk about indirect and direct routing. What happens is you talked earlier about the blurred boundaries between healthcare and law enforcement. And what I saw in my interviews was, with pharmacists in particular, that they're much more inclined to call law enforcement when they see something that they think is suspicious about a patient. So they'll call them and say, this patient, I think there's something going wrong with this patient. You should check them out. There's one pharmacist in the book, Min, who talks about helping law enforcement catch a patient. He put candy in their pill bottle. He called law enforcement so they were there ready to arrest the patient. And this just, I think certainly we should be concerned about medication fraud, but we should also be concerned about the healthcare provider-patient relationship.
Right.
And so this kind of routing, I think, not only blurs these boundaries, but also might lead patients to avoid the healthcare system entirely, and that can be problematic as well.
And what charges would patients then potentially be facing?
It really depends on the case. So in that case, it's fraud,
right,
or drug diversion. There are a number of different things they might get charged under.
Now, the last time that you were on the show, you mentioned pharmacists, and we did talk a good bit about pharmacists occupying a peculiar, that is to say, a particular and sort of uncomfortable and untenable place in the way that prescription drug medication programs work, especially with that sort of law enforcement matrix. And to get a sense of how pharmacists in training are being prepared to use prescription drug monitoring programs, we contacted Amy T. Meyer, who is an associate professor of pharmacy practice and director of community partnerships at the University of Health Sciences and Pharmacy in St. Louis. And Amy says that in the St. Louis College of Pharmacy, educators tell their students that prescription drug monitoring programs are a tool to be used. They are not a definitive solution to a problem.
And so we really talk to the students about this is a tool that helps you make clinical decisions. So we don't make assumptions. We don't just say, okay, if we see this alert, we're cutting people off. It's like you have to really look into the data. You have to know how the alerts are generated to understand what those alerts really mean. I think there is less this patient-specific data available with the statewide PDMP than there was when we had the county-based system. And so we talk to the students about, you need to understand the system, you need to understand what that data is telling you, and then you need to take that in context of everything else you know about the patient and think about what other questions you need to ask. And think about it from, what are my concerns? Do I need to clarify any information? Do I need to verify that the prescriber or prescribers are aware of this? And sometimes they are. So for one patient, their medication profile may be completely justified based on their medical conditions and everything else that's going on. Another patient with a similar profile or maybe similar alert, maybe there are more concerns there that we need to start asking more questions and doing more to support and thinking about, how do I keep this patient safe given the current scenario? How do I maybe encourage them to get help if we think help is needed? Or how do we even assess based on this alert if we need to take further action or do more education around, risks and benefits and staying safe?
And on that note of staying safe, Professor Thiemeyer also mentioned a new partnership between area universities and the Missouri Pharmacy Association that will train pharmacy technicians as community health workers. When a patient is identified at the pharmacy counter as potentially having substance use disorder, those pharmacists will work to connect that patient with resources.
Whether that be getting them into recovery type services, or if they're not at the point of, wanting to go into those kinds of services, that connecting them with other organizations that would help with harm reduction. So even something as simple as providing naloxone or making sure that they're understanding safe use and things like that. So really trying to support the patient wherever they're at.
That was University of Health Sciences and Pharmacy in St. Louis Associate Professor Amy Thiemeyer talking about a new training program. The coalition is being led by a researcher at Washington University with facilitators from the Missouri Pharmacy Association, the St. Louis College of Pharmacy, and the University of Missouri Kansas City School of Pharmacy. Liz, is there anything in what you heard there that's reflective, that is, of why you have written papers that do have a focus on pharmacists in particular?
Absolutely. So first of all, I'm really thrilled to hear about this program because so many of the pharmacists that I spoke with, I asked them, you're a healthcare provider. A substance use disorder is a medical condition. Do you have any resources to help people get into treatment, or to get some access to care? And they usually told me they had nothing. And so to hear what Professor Thiemeyer and her colleagues are doing is really exciting. I think it's one thing, however, to educate pharmacists about what they should be doing, and then it's quite another thing to be in the pharmacy and to deal with all of the pressures that happen when you're at work. And what I found in my research is that pharmacists are being urged to be both efficient by their employers and to be cautious by law enforcement. And that was really where the source of tension was for them. They didn't know how to do both at the same time. And the PDMP, the prescription drug monitoring program, looks like it helps them do both. But I think what Dr. Thiemeyer was saying is actually really important. You can't just take the information from the PDMP. You can't just look at a risk score and say, oh, clearly we shouldn't provide medications to this patient. You actually have to dig a little bit deeper. But that undermines the efficiency of the PDMP. It would be great if you could look at a number and make a decision.
Right.
But ultimately, pharmacists are professionals with discretion who should use that discretion to help their patients.
We need to take a quick break here, but we'll be back shortly to continue this conversation. This is St. Louis on the Air on St. Louis Public Radio.
If you have a smart speaker, you have access to the entire world of NPR and St. Louis Public Radio. All the latest news and all the captivating stories. Activate our voices with yours by telling your smart speaker to play St. Louis Public Radio.
Welcome back. Let's return to our conversation with Liz Chiarello, Associate Professor at St. Louis University and author of the new book, Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis. So Liz, before the break, we spent a good amount of time talking about the effect of prescription drug medication programs on what is expected of pharmacists and what they are dealing with. Now, what are the effects of these monitoring programs, however, on law enforcement?
In many ways, prescription drug monitoring programs have made law enforcement's job easier. So it used to be the case that if law enforcement was going to target a physician, they would have to go from pharmacy to pharmacy to pharmacy to get all of that physician's prescriptions. That's a lot of legwork. It takes a lot of time, and what they came up with would be incomplete. The PDMP turns that legwork into desk work. So instead of traveling among pharmacies, they can either get the data directly. In some states, they have a login. In other states, they have to get it from the organization that houses the PDMP, which is usually the Board of Pharmacy, the Board of Medicine, sometimes Consumer Affairs. So then they get that information, and then they can do things like, sort by doctor, sort by volume, do some basic statistics. And so that's made that work a lot easier. And then they also can combine PDMP data with data from other sources like ARCOS, which is a database that the DEA uses to track opioids from their manufacturer all the way to their end user. And so it's a really helpful database for them in terms of figuring out what doctors are doing.
Mm-hmm. So they like this.
They do. Yeah, they do like it.
Mm-hmm.
They do like it. Everyone who uses it seems to like it.
And there's no competition over who's over it or who's in charge of it.
I believe historically there was probably a political fight in terms of who got to house the prescription drug monitoring program. But the bottom line is, that private company that I told you about, Bamboo Health,
right,
that consolidates all of that information and feeds it back. That's a really important actor in this story. And so regardless, in fact, I designed my research to see if there would be variation depending on where the PDMP was housed. Mm-hmm. I didn't really find a lot of variation.
Right.
And I think part of that is because it's been consolidated within this single company. Mm-hmm. For the most part, not every single state uses Bamboo Health, but most of them do.
Right. And Missouri does in fact use Bamboo Health. What about doctors? There's quite a bit in your book about the way that doctors interact with, engage with, feel about prescription drug monitoring programs. Tell us a little bit about that.
What happens with doctors is they use the PDMP, the prescription drug monitoring program, alongside other enforcement tools. One of the most popular tools that doctors have started using is called the pain contract. And a standard pain contract will say, I am your only doctor. You're only going to go to this one pharmacy. You're not going to go to the emergency department to look for opioids. I'm going to test your urine at random. And some of them say, if I want to, I can text you and say, show up at my office within 24 hours because I'm going to count the number of pills that are remaining in your pill bottle to make sure that you're taking these drugs as prescribed. I just want you to imagine for a second us doing that with any other kind of medication. Think about your blood pressure medication or your cholesterol medication, mm-hmm. and your doctor saying, show up and I'm going to count the number of pills in your bottle. How you might feel about that.
Yeah. I mean, what I was feeling as I was reading about some of the doctors who do use these pain contracts is that there is more of a fear of litigation or damage to their reputation than there is a concern about humane patient care. I mean, is this one of the consequences of prescription drug monitoring programs? Is it more of a symptom of the way that we as a society regard people and their pain?
I think it is mostly the latter. I think the prescription drug monitoring program is part of the set of tools that doctors use to police patients, and it is part of a process of criminalizing care. But we also, as a culture, treat people who have substance use disorders and people in pain quite terribly. And so I think we look at the policing of them and think, well, that's never going to happen to us. But increasingly, we're seeing more policing around other kinds of marginalized care, things like abortion, contraception, in vitro fertilization, gender-affirming care. And so I think this really sets a troubling precedent, especially given that physicians take an oath, not just an oath to do no harm, but an oath to put their patients first. And unfortunately, they've been put in a position where they're practicing defensive medicine instead of honoring that oath.
So, Liz, last week you were preparing for this segment and we saw an NPR exclusive come through. And in that exclusive, there was a report about a sudden nationwide drop in drug overdose deaths, and that's nationwide. And it was based on public health data that showed, an unprecedented decline in the number of drug deaths. What did you make of that report?
First of all, it's incredibly exciting. We haven't seen that big of a drop the entire time we've been stuck in this crisis. And so it's very exciting. But I think the important thing is we have to get the story right. What happens when we have social change is a lot of groups want to take credit for it. And we as researchers have an obligation to find out exactly what factors led to those declines. And then our political leaders need to go all in on what works. And there are a lot of people speculating about what might be leading to the drops. The widespread availability of naloxone, increasingly available treatment, the fact that we just got out of COVID. But I do really want to put those numbers in perspective. So imagine for a minute that you were losing $10,000 a month, and then things changed and you were losing $8,000 a month. You would be, I think, relieved, but I don't know that you would be entirely celebratory. And these are not dollars, these are lives. And when you keep in mind that every single one of these deaths is a preventable death, even that decline, even though those declines are good, we still haven't gone far enough to save the lives that we can save.
Right. In the last minute, Liz, your book is dedicated, quote, to those who are suffering and those who want to help. Is that where you started, or is that where your research and the stories you heard from people led?
It really is where my research led. I came in, I knew very little about drugs. I didn't set out to be a drug researcher. And I think the best research changes you as a researcher, and mine certainly has changed me and helped me see multiple sides of this story and really devote myself to helping the people who are suffering.
Is there maybe one reaction that you've had that is showing that it's doing that?
People who have read the book have been really receptive and have said that it reflects their experience. And to me, that's the best compliment I can get.
Liz Chiarello is Associate Professor at St. Louis University. Her new book is titled Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis. Liz, thank you so much for joining us today, and congrats again.
Thank you for having me.
This episode was produced by Emily Woodbury
and by Elaine Cha.
Audio engineering and podcast design by Aaron Dorr.
Our executive producer is Alex Hoyer.
St. Louis on the Air is a production of St. Louis Public Radio. Understanding starts here.
Do you find yourself regularly listening to episodes of St. Louis on the Air? Suggest us to a friend you think might enjoy our conversations. And leave us a review and rating on Apple Podcasts on the App Store. It's the simplest way to help people discover our show. Thanks.
St. Louis Public Radio is a member-supported service of the University of Missouri St. Louis.
The Gateway brings you the day's news each weekday from around the St. Louis region and the state capitals in Jefferson City.
Our schools are accredited. We don't need this bill.
And Springfield.
How many more years must pass before lawmakers see time is of the essence?
I'm Abby Larico. Join me each weekday for The Gateway on the STLPR app or wherever you get podcasts.